Welcome to the First Principles of Medicine podcast. In this series, we will be breaking down complex medical topics into their first principles. When the stress is on and you've just been asked a tough question that you don't know the answer to, we feel you'll be able to fall back on these principles to formulate a decent answer and perhaps reason your way out of trouble. On today's episode of 1PM, Daniel's going to be talking to us about DKA. Take it away, Daniel.
Good morning, good afternoon, everyone. How you going? I'm Daniel, and it's myself, Jason, Adian, and JT, and we're going to be going through some hopefully high-yield conditions, so you can just, listen along and hopefully get something from it. Today we're going to be discussing diabetic ketoacidosis.
Love it.
So guys, tell me, what do you know about DKA?
It's potentially life-threatening.
Mm-hmm.
Yep.
Happens in diabetics.
Yeah.
Oh, wow. So profound,
I'm
JT.
trying to break it down.
That's okay.
Ketoacidosis, right?
Yeah.
So keto for ketones,
Yep.
acid for acid, osis in the blood?
Does it happen in all diabetics?
No.
No. Okay.
No,
So
no.
what type of diabetic?
I believe type 1 diabetics, mostly.
Okay.
Actually, I can't say. Nothing in medicine's ever set like that, right? But I assume it's mostly type 1. I assume you can get it in type 2, but not as common, right?
Well, let's talk about this. Okay. Does anyone know the pathogenesis behind it?
I do not.
I know a bit. So it's
Tell me what you
basically
know.
when you've got very, very poorly controlled type 1 diabetes. Or maybe not. You know what, Dan? I actually don't know.
I think. Can I give it a go?
Yeah,
So I think with type 1 diabetics, you don't have enough insulin,
Okay.
which means that you can't get enough glucose into your cells, or you can't use enough glucose, and then therefore the body goes into the secondary drive for sugar using ketones, and then a byproduct of ketones is acid, and then that causes acidosis in your blood.
Okay. There's a bit to it, but
Yep.
first let's think about DKA. So what does the patient have in DKA in terms of their bloods? So we do a blood test on them. We're looking at their blood sugar levels, looking at their ketones.
Okay,
So pH is low.
Okay,
It's acidic.
that's if we do an ABG.
Okay.
So let's just start with the blood.
We'll do like this. They've got hyperglycemia. Okay, we're talking
Too
about
much glucose.
pathogenesis. They've got too much glucose.
Yep.
Okay. So if you've got hyperglycemia, what's going to happen? Where's that glucose going to go?
So usually glucose is either taken up by tissue or it's urinated out if it's very high.
Yeah.
But in general, do you want to retain glucose? So it's usually not peed out unless it's very, very high levels. So
Okay, yeah, that's true. But okay, let's talk about type 1 diabetes then. What is type 1 diabetes?
We're not hitting his
Sorry, am I going
his
too fast?
reasoning.
A little bit slow, yeah.
Let's talk about type 1 diabetes.
Yep.
Type 1 diabetes is an absolute deficiency in insulin.
Yep.
Okay?
Yep.
Your cells aren't taking it up. There's no insulin.
Yep.
So in simpler terms, you're not producing insulin in type 1 diabetes.
Yeah. Okay, that's why we give insulin replacement, the basal bolus regimen.
And that's why it's insulin dependent
Yeah.
diabetes, right?
Yeah, versus type 2 where you've got a little bit of insulin in the background, your cells are just becoming a bit more resistant to it.
Yeah.
Okay. DKA happens in type 1 diabetics, all right? Because
Yep.
you can go into periods where there's no insulin in the body
Sure.
at all. If there's no insulin in the body, the cells can still take up glucose normally, but they need insulin. If there's no insulin, the cells won't take up glucose, all right? This is going to lead to hyperglycemia, all right? When you've got the hyperglycemia, the glucose isn't going into the cells, all right? And so you're going to start urinating it, peeing it out.
Right,
You can
okay.
have glucoseuria.
Glycosuria.
Glycosuria. When you've got more glucose in the urine, what's going to follow?
Water.
Water. All right? So it's osmotic diuresis. You're going to be getting rid of, glucose
Pee out a
and
lot,
water,
yeah.
peeing it all
Polyuria
out.
then.
Yeah. All right?
Do
So
you
get-
also, is this why you also get polydipsia?
yeah, so you would get polydipsia as well. All right? Why are you getting polydipsia?
Because you need to replace the
What
water
is
that
polydipsia, JT?
Oh, yeah.
I don't know what poly means a lot. Dip, I don't know. Like drink? Or
Well,
the
what is it?
urge
Yeah,
to,
yeah,
urge to
yeah.
be thirst. Is it?
Thirsty. Yeah.
First.
Yeah.
Yeah.
Okay. So you get, with this osmotic diuresis, you get polyuria, polydipsia, because you're dehydrated. And you have this inability of your cells to use glucose for energy, okay, because you don't have any insulin. So from this, you switch on, you start using your fatty acids, you start breaking them down, okay? And you break them down into ketones.
Oh, okay, I missed that step.
That's all
Yeah,
right.
okay, yeah.
And that leads to ketonuria and ketonemia. Now, you've already weed out all the excess water
Yep.
Okay, so your body can't keep weeing out all these ketones, and they start accumulating. All right, and this leads to a metabolic acidosis.
Yeah.
Okay,
Yep.
and that is DKA.
Sure.
Does that make sense?
Yeah.
Mhm.
I
Makes
follow.
sense.
Yep.
Cool. So, thinking about that, what are some of the signs and symptoms of DKA that we really should be watching out for, because this is a common presentation to ED?
Okay. So, going on the first principles, obviously. So, if you peeing out a lot of sugar is drawing the water, so you're going to be peeing a lot. So, someone might complain of going to the bathroom very often.
Polyuria.
Yep. They might, as JT mentioned, because they're peeing a lot, they might feel very thirsty. So, they might report drinking a lot of water as well, but still peeing a lot, still feeling thirsty.
I mean, they're dehydrated as well, so you'll go
dehydrated.
through, I think the renin-angiotensin, like RAS system, I think
Sure.
that can stimulate thirst as well when it gets to the ADH side
Yep.
of it. But now thinking specifically that we're talking about type 1 diabetes here, think about DKA. So this is more of an acute
on
type
the
thing.
DKA. Okay.
So I think one of the things with the metabolic acidosis is that you get a compensatory mechanism.
Yeah.
Is that what we're looking for?
No, so I'm looking for nausea or vomiting.
Oh, okay.
More acute things like that. Dry mouth is a good one. Thirst is a good one. Nausea, vomiting.
Why does it make you nauseous and make you want to vomit, Daniel?
So you're going to have a metabolic acidosis. Okay. Centrally, this is going to be picked up, and it stimulates nausea and vomiting through the D2 receptors. I don't know too much more.
D2 dopamine?
Dopamine, I think, centrally.
Do these because you're acidotic, do these hydrogen ions cross the blood-brain barrier?
Yeah, well, that's
why it's stimulating the nausea vomiting? Or
you're not 100% sure
Right, okay.
exactly how that works.
Yeah.
Because it's a relative acidosis, because you've got an accumulation of ketones in your blood, which will cross the blood-brain barrier, actually. But
the brain does use ketones, right?
Yeah, no. So that will
yeah.
cross, but I'm not sure if that will. I don't know exactly. I was looking, but
That's
it was not
okay.
clear.
Yeah.
Sorry, guys. What signs could we find? Could the patient have? Actually, no. Sorry, I forgot one important one. Let's go back to presentation. They could also present with shortness of breath.
Yep.
Okay. Why is that?
JT mentioned it before.
I was gonna say the compensatory respiratory, hyperventilation.
Yeah.
To get CO2 out of the body, and then I think as a result that raises up the blood pH.
Yeah.
To become less acidic.
Yeah. So the bicarbonate buffer system. You're just working on that little equation.
Yeah.
Okay.
So the hyperventilation. But
Yeah.
then you said short of breath, and is that because of the hyperventilation?
Yeah, they'll feel short
Yeah.
of breath. They're trying to breathe it off
Yeah.
a bit more.
Sure.
Okay, so they're dehydrated. Okay, they've got hyperglycemia.
Okay.
This has led to a dehydration. Thinking about that, what are some of the clinical signs we might look for?
Clinical signs of dehydration would be things like low blood pressure.
So we're looking fluid.
Fluid,
Fluid
So
assessment.
if you're hypovolemic, you've got probably low blood pressure. You've probably got tachycardia to help compensate with that. Probably got things like dry mucous membrane and reduced JVP.
Yep.
Every physician's favorite sign. What else?
On your skin, I assume?
Skin turkey. That's got to be the most useless sign. Okay, seriously. How do you compare people's skin turgor? Like, what happens if they just don't moisturize? Hey,
Or they're old.
That's not the same thing,
it's not
is
the
it?
same thing. No, because skin. It's like when you peel it, like when you pull it up.
Peel the skin.
When you pull it up and it doesn't bounce back immediately, that's the sign of reduced skin turgor.
Anyway, in my opinion, stupid sign.
Not dry skin. Not exact signs.
And possibly.
But if you're talking about type 1 diabetic, they're usually not that old, right? So
Yeah, but they can go into DKA at any time.
yes, yeah. I think what you were saying, Jason, was you're probably talking about the elderly who have reduced skin
All
turgor.
I'm saying is that skin turgor has never saved anyone's life.
Well, it's probably not the one thing that will point you towards, So
the most bang for your buck, the most important signs of dehydration, in my opinion, would be low blood pressure, tachycardia, and a reduced JVP.
Yeah.
Sure.
Yeah, reduce
I feel the other ones are a bit more subjective.
At what angle?
30. So you need to have a what are the things called measure the angles? What are they called?
Rulers?
No, not
Compass,
ruler.
protractor?
Yeah, protractor. It's called protractor.
Compass.
Anyway, just
Whatever.
carry one of those with you at all times. Okay,
Are we
sorry
missing
about
anything?
No,
Dan?
that's fair enough. That's most
So
of
signs
it.
of dehydration.
Yeah, looking for tachycardia, hypertension, reduced skin turgor, dry mucous membranes, reduced urine output. They might have altered consciousness and Kussmaul's breathing.
Tell us about Kussmaul's
Wait,
breathing.
is this Kussmaul's deep breaths? Deep, rapid breaths?
Yeah. Deep
Okay.
breaths.
So those deep, rapid breaths are because of the...
They're trying to, the metabolic
Compensating?
acidosis,
Yeah, the
they're trying to
compensation.
breathe
Yeah.
off.
So that's from the
So
hyperventilation.
as opposed to sometimes you hyperventilate with short, shallow breaths, but rapid, short, shallow breaths, right? So this one will be deep, rapid breaths.
Yeah, okay. Cool.
All right, we're going a bit off topic here.
Yes.
So now let's bring it back, okay?
Bring
so
it back.
we have a patient, we think they have DKA. We got to make sure that they've got DKA. How do we confirm it?
Do a finger prick blood glucose, check
Yep.
their ketones.
Yep. How
As
do we
you
check the
normally-
ketones?
I actually haven't done that, but I assume ABG.
Yeah, well, I think it's either blood urine for ketones, either a urine
Okay,
stick,
right. Yeah, you can do the
Urine
zip stick.
analysis,
Yeah.
urine analysis. So ketones more than 3.
3
in the
okay.
blood,
Yeah,
okay,
okay.
or positive on urinalysis. And then we do an ABG,
Right,
Mhm.
okay.
okay? Tell me about interpreting an ABG.
Jesus.
So
Do you,
with,
wait. Do you do a VBG first and then an ABG? Or do you jump to an ABG if you suspect DKA?
I thought you just go straight for an ABG.
If you're DKA, you need... Because you're looking at arterial blood, not venous blood.
Okay.
Because
yeah.
venous blood the values for venous blood are different to
Mm, mm.
arterial blood.
Yeah.
So you need an arterial sample.
Okay.
Okay, so actually, Adian,
Mm.
start us off. How do we know that? So what's the first step in interpreting an ABG, to my understanding anyway?
You make sure that the sample belongs to the correct patient.
Assessment of data.
Smart ass.
Well, I'm not wrong. Nah,
You're
yeah.
not wrong.
No, fair.
But you've stuck the needle in them.
Yeah,
You know it's
I've
them.
stuck the needle in them. I've taken the sample to the
Mhm.
machine. Would
Going
you,
to first principles.
Would you... Yep, so you're looking at arterial blood. You look at the blood oxygen,
Yes.
essentially.
Yeah. And what are you looking for there?
So you're looking for a partial pressure of oxygen of 100 millimeters of mercury?
Well, 90.
90
above,
90,
something
100.
like- or 94 to 100.
Yep.
Okay. What if it's down in like 46?
So it's down into 46. That could mean most likely you're in a vein.
Yeah. So looking at the
Yeah.
PO2.
Oh, really?
Venous
Yeah.
sample, yeah.
Looking at the PO2, if it's too low, it's probably a VBG, not an ABG.
Right, okay.
Okay. If it's 94 to 100,
Mm.
great, probably an ABG.
Mhm.
Okay. What do we look at next?
The other gas.
you look at the pH.
Yep.
pH.
Oh,
Okay.
okay.
So pH less than 3.5,
That's pretty
3
acidic.
3.5.
That's pretty acidic.
7.35. Shit.
That's pretty acidic.
Yeah. Ooh, they're dead.
Yep.
So what is the normal range?
I think it's 7.35 to 7.45.
Yeah.
Yes.
Really narrow range, right?
Yes.
Yeah.
Very narrow range.
Yeah. So in this case with DKA, you would have a pH less than 7.35.
Yep. Okay. Then what do we look at?
The other gas.
Yeah, the other gas. Okay, so we're looking at the PCO2,
Yep.
and then we look at the bicarbonate. Okay,
Mhm.
what would we expect to see? So we're looking at a metabolic acidosis with respiratory compensation. What is that picture?
Low CO2. Lower than the range
Yeah.
because you're breathing it out.
Yeah.
I don't know what the range is.
Yeah.
Yeah.
And then you might be trying to retain bicarbonate.
Mhm.
Yeah,
Okay, so
because with
that's easier.
hyperventilation, you're blowing off CO2.
Okay,
Yep.
great.
So to summarize, if Jason over there secretly diabetic, hasn't told anybody, doesn't have his insulin at hand, goes into DKA, JT pulls out a needle, sticks it in his radial artery and draws an arterial sample, looks at the gas interpretation, he will see a high PO2 between 94 and 100 millimeters of mercury. That should be normal. But his pH
Mhm.
might be lower, so
Yep.
less than 7.35. His carbon dioxide might be lower.
Yep.
PCO2 should be lower as well.
Because of
Alright.
hyperventilation.
Yeah. And bicarbonate would be higher.
Higher to
Okay.
compensate for the...
Great.
Yeah.
Sounds good.
Yeah, so apparently though, the severity of the ketosis or the DKA is kind of linked to the bicarbonate levels. If you've got a very low bicarbonate levels, it probably means you've got a very severe DKA.
Yes.
Mm-hmm. Want to explain why, Jason?
Because bicarbonate is a base,
Yes.
and bases neutralize acids.
Yes.
So less bicarb probably means you have less ability to neutralize the acidosis.
And if you've got less bicarb, why could that be? Either you've used too much in the bicarbonate equation, so you've breathed it all off as CO2, or you're not absorbing enough from the kidney, from the urine. You can't reabsorb.
Oh,
I have no idea.
where
That
do you
would be-
get them?
I
Where do you
think-
get
yeah.
bicarbonate from normally?
But you can normally, I think, reabsorb it in the urine.
Yeah. Okay.
Yeah.
Cool.
I'm not going to go into the anion
No, you
stuff
don't need to.
because
You
I
don't
think
need to do
that's
that.
where we
This
understand
is,
it.
this
But
is
yeah,
a bit beyond.
I think that would be a large anion gap, which a high anion gap actually, which is what DKA is. It's a high anion gap.
Yeah, I
Metabolic
always-
acidosis.
Just to plug something, this is not. There's a very good website for interpreting ABGs. It's called ABG Ninja.
Oh.
Basically, they just present a bunch of
Just
ABGs.
ABGs.
Yep, and there's ECGs as well.
Oh,
You
okay.
just present a bunch of ABGs and you read through it and you work out how to read an ABG. It's very good. This podcast is not sponsored by ABG Ninja, but would recommend.
Okay.
All right.
You think they've got a metabolic acidosis? Think they've got DKA? What are some of the things that can precipitate DKA?
So I think the most common thing, just based off humans and their ability to forget things, would be to forget to take your insulin.
That is one of the most common.
Yep.
Because people are idiots, including me, including you.
So the second most common cause is infection. Why would infection cause this?
Because when you've got an acute infection, what hormones do you get released?
Cortisol.
Yes.
And what is the main function of cortisol?
Well, cortisol is a stress hormone, helps you deal with stressful situations.
Okay.
But one thing it does is raises blood sugar.
Yeah, so raises blood sugar is effective cortisol. Okay, what's the other one? When you stress, man, what's pumping through you?
Adrenaline.
Adrenaline. And what effect does adrenaline have on your blood sugar?
Decreases. Increases.
Yeah.
I don't know.
Increases.
A fun.
Oh, sorry. It brings out from your stores so that I guess when you're fight or flight, then you need the sugar to to access.
Pro tip, I remember from a lecture, was that basically insulin is the only hormone
That
which
drops.
reduces your blood
Yeah.
sugar. Everything kind of else increases it. So that's an easy way of kind of remembering. That's why insulin's so important. Okay? But
Okay,
yeah,
Daniel,
cortisol and adrenaline.
So, are those the two main hormones?
Yeah, so glucagon as well, but that's another stress thing. So the stress response will bring out these hormones.
Yep.
Okay, they're going to increase your blood sugar, and as we discussed before, back to first principles, that means you're going to wee out more glucose. You're going to be more dehydrated. Okay, and you're going to increase your production of ketone bodies through the beta oxidation of fatty acids, and eventually you'll get into a DKA state. So yeah, so physiologic stress, infection. I think apparently an acute MI can do it as well. Things like that. Okay. I think there's a bunch of I's. So 5 I's.
But in general, just think of anything which makes you unwell. Like,
Sure.
So infection, infarction, infant. So if you've got a fetus, that's
Oh
sucking
yeah,
the
it's less
life out of
stress.
you.
Yeah.
big tumor.
Yes.
Wait. having the baby or having a kid
And having a baby inside.
Being
within
pregnant,
you. So
like-
Pregnancy.
pregnant women.
Yeah.
Okay.
Just
So
talking to
indiscretion.
JT on a infrequent basis would make you stressed.
So another one of the I's is insulin deficiency.
So I was just wondering, if someone regularly takes their insulin, but they have a really ridiculous amount of sugary meal, can that not lead to DKA?
Well, that will lead to hyperglycemia. But the fact that they have their insulin in the system means they're still getting glucose into the cells, means they won't produce ketone bodies.
What if your insulin becomes depleted?
That could lead to,
So
dermatol.
you got to think of your insulin at relative levels, right? So when you've got absolute insulin deficiency, okay, so you've got 0, let's say your numbers go from 0 to 1, 0 to 100, okay? If you've got 0 insulin, that leads to lipolysis and ketosis. But let's say in a type 2 diabetic, they've got like 10 insulin or something. That prevents the lipolysis and ketosis from occurring. Do you know what I mean? Even though they don't have the right amount of insulin, just that little bit of insulin, I think, prevents the acidosis.
Won't that deplete over time, though? Your amount of insulin in your blood?
Yeah,
But as long as you've got a little bit, you won't go into
Yes.
DKA.
So
That's why
Oh.
type 2 diabetics don't go into diabetic
because
ketoacidosis.
usually, even though
okay.
you can get insulin-dependent type 2 diabetes, usually they may have like some insulin, but It could be like 5 or 10.
Right. So
out of
that's why you're
100.
emphasizing the absolute insulin
Yes.
deficiency.
Yeah.
I see now. Okay. Right.
Absolute.
Okay.
insulin
Let's emphasize that
deficiency.
again. Double absolute.
So back to the causes.
Yeah.
So if infection can cause DKA,
Yeah.
how would you screen for it?
So you, if you're doing a urinalysis for their urinary symptoms, you might you might be able to see the presence of bacteria.
Yeah. So you're looking for a
Nitrites,
UTI.
you're looking for UTI.
Yeah. Yeah. Anything else?
Just
Um,
normal bloods and then you check their white blood cell count,
Yeah,
their
so white cell
CRP,
count, yeah,
ESR.
CRP, yeah, cool.
Any like sort of clinical symptoms or signs of infection, like high temperature,
Great.
you know, sort of coughing, sneezing, running nose.
Yeah. With the infection as well, maybe a chest X-ray.
Mhm.
Maybe they have a
Mm.
pneumonia.
Mhm.
Okay, something along those lines. Maybe
Mhm.
they've got another illness like an acute exacerbation of COPD or aspiration pneumonia or something.
Mm-hmm.
If they've had an MI, what would you do to try and look for that? Say they had chest pain beforehand. What are you going to do?
The
ECG.
bedside test, ECG.
ECG, yeah.
Good. Okay. Now let's go on to management. How do you manage someone with DKA?
What is the most important?
Mm.
What is your... If you only can choose one thing, JT.
It's got to be the insulin, right?
Yes,
No?
I wouldn't think so.
it is.
Bring you back to dehydration. Hydrate them.
Yeah, but
You'll
it's
dilute
insulin.
everything.
That's
My
the-
man,
no,
my
but in
man's
the
my
short
insulin.
in the short term though, in the immediate term, you need to.
If you
I
if you
believe it's insulin, my friend.
Okay, hang on. If you had to choose one... Actually, no. We'll
Wait,
discuss this
describe
after
the-
we
yeah,
go through
yeah,
everything,
yeah,
because I'll
okay,
give things
okay.
away.
We'll
otherwise.
table this. Okay.
We'll come back to this. How do you manage someone with DKA?
rehydrate them.
Why?
Because you told me earlier they are dehydrated
Yeah.
and they're pissing a lot of piss. So you've got to get their water status back.
Great. So
Would you also, as part of the rehydrating, would you then dilute the acid?
Yeah.
So you reduce the severity of the acidosis.
You know, I'm not saying saline doesn't help, guys. Just saying you give them insulin.
but you would also allow them to weigh out more of the
Mm.
ketones.
Mm-hmm.
Okay.
Mm-hmm.
Now, yes, you do want to give them insulin, but should you check for something else before you give them insulin?
They're not allergic. I don't know.
Okay, say someone comes in with hyperkalemia. What do you do? How can you reduce someone's blood potassium?
Oh my god, fuck that thing.
Insulin transports potassium into the cells.
Yes. So it
So
can cause hypokalemia.
So you need to check that their potassium levels are all right
before you give them insulin. You check that their potassium levels are not too low, and you probably give them some potassium. Then you give them insulin.
I see. So question is, if they were normal kalemic and they were dehydrated, which one would be more immediate for their
You always just
management?
you start pumping them full of. Sorry, I spoke to a resi about this the other day.
Mm.
Apparently, you pump them full of fluid. You're probably on the second bag. You're going to give them some potassium anyway, even if they are normal kalemic.
Why is that?
And give them insulin because you are going to reduce their
protective.
potassium. Yeah.
Oh, just by urine output.
No, because an insulin drives potassium into cells, so you're going to reduce the blood potassium.
Sorry, but which one's more acutely can fix them up?
You don't think is you don't do these in isolation.
Yeah, okay,
As in,
sure.
You do them together.
Yeah, okay,
Yeah.
okay.
I think
Okay.
I think it's hard to think of them. Maybe my question to you of just skipping one is probably wrong, but I think you have to do all of these things in conjunction.
Yeah, okay.
Excellent. So,
So
and finally, what's the final thing you want to do? We're treating this patient holistically.
Love
Alright.
it.
Let's say...
I would put this first, actually.
Yeah, but let's say they're dying. You
Yeah.
want to stop them
Yeah,
from
yeah,
going
yeah.
into a coma and
Fair.
dying. So we've treated them. You
Yeah.
know. Now we're going to treat them holistically.
Yes.
Let's say, for instance, our patient has done this because they missed an insulin
Yes.
dose or something. All right.
Yes.
What do we want to do? The final step.
Patient education.
I should have said multiple final steps. Yeah, patient education. Okay.
Yes.
Maybe, get a diabetes educator
Yeah,
involved.
be educated, yeah.
Okay, maybe change around their, medication regimen. All right, this is
Maybe-
beyond me at the moment. And outpatient follow-up with the GP.
Yeah.
All right, we're in the hospital in this setting, so
Yes.
we want them to be followed up in the community to try and stop this from happening again.
Love it.
I
Fantastic.
actually met a type 1 diabetic over dinner once, and then he had one of those patches on his arm, and every now and then he would just, over the day, not over dinner, but he would
Fine, yeah.
do it, and then he
Yeah.
would just check his blood glucose. I was like,
It's like the app
yeah,
on
they're
his
pretty
phone
cool.
one.
yeah,
Yeah,
and he
yeah.
could, and then he was like,
Yeah.
oh, I can I can align this with periods that I feel stress over time. And I guess it makes sense now because you're talking about the stress, the adrenaline, cortisol can potentially increases blood glucose. Oh, another sign. Don't you get like this fruity smell?
Oh, the acetone breath.
Yeah, that's a
That's not
clinical
really a
sign, right?
DKA.
Is that common or?
Ketones.
But there'll probably be more.
If you didn't eat for a few days, you'd get that smell
Hmm.
because your body is processing ketones, so you'd actually get that smell.
Oh, I
Yeah.
wonder if Serena had that smell. I actually don't remember it now.
She fast for a few days.
No, she went on a ketone. No, didn't you go on a ketone diet, Dan? For like a while.
Oh, years
You
ago.
go keto, yeah.
She went keto, but
Yeah.
I don't remember smelling it. But did you remember having a funny breath?
No, but I'm smelling my own breath. Anyway, let's summarize for today. Okay.
Did me ever
So,
complain?
we've talked about DKA,
Yeah.
diabetic ketoacidosis.
Yeah.
Yep.
All right. It's caused by,
Absolute insulin deficiency, bitch.
well, yeah,
And?
and
And
excessive
high
ketones.
glucose in the blood.
yeah, high glucose in the blood. Okay.
High
called-
ketones.
High ketones,
Oh,
causing the osmotic diuresis, and high ketones because you've got activation of oxidation of fatty acids.
Beta
produced.
oxidation.
Yep. Cool. Okay. So you'll have someone presenting, you'll do an ABG on them, they'll have a low pH, so less than 7.35. If you calculate the anion gap, they'll have a high anion gap metabolic acidosis, okay? And they'll have hypoglycemia, okay? Most of the time. In the history, they may have had nausea, vomiting, all right? They may have had abdominal pain, dry mouth, okay? They may, if it's quite bad, they maybe have a coma, okay? You do a volume assessment, you assess and make sure there's no infection, okay, because that can precipitate this. Do a GCS, see if they've work of breathing. Investigations, as I said, ABG, you'll be looking at their electrolytes, looking at the potassium and all of that. You'll be looking urinalysis, looking for ketones, pregnancy test if it's a young lady, and just normal things, FBC, ECG, chest x-ray, okay?
Just wondering, in terms of the anion gap as information you need to know, can you, for example, if you just look at their pH plus their CO2 level plus their bicarb level, is that sort of enough to tell you about their acid balance state, or do you need to look at the anion gap?
Well, hang on. It'll tell you if they have an acidosis or an alkalosis or something like that. But I think for the anion gap, you actually need the concentrations of the ions.
No, but I mean, what information does the anion gap give you that the other ones don't?
So you can have a high anion gap, like metabolic acidosis, and you can have a normal anion gap metabolic acidosis.
Right,
so it
okay.
narrows down the causes.
Right. Okay. I see.
Yeah. So I think that's the function.
So
of that.
that points to what's causing your metabolic acidosis. Okay.
Yeah, so if it's a DKA, high anion gap,
gotcha.
metabolic acidosis.
Yeah.
Other causes could be, I think, alcoholism, or alcohol intake can precipitate it, lactic acidosis, renal failure, things like that.
And that's narrow. That's
high anion gap.
Oh.
metabolic
Do you know
acidosis.
what a normal anion gap metabolic acidosis might be?
I think adrenal insufficiency can do it.
okay, whatever.
No, I think it's just important because, like, say for example, if you get asked on the wards, like, can you tell this patient is so and so? You can tell what are some possible causes, and if you know certain causes are lead to a high anion gap, it could be maybe it's one of these three, whereas a normal anion gap it could be maybe one of these three, and so it just puts you in a better position.
Yeah,
that's all right. Gold mark is a mnemonic for the high anion gap metabolic acidosis.
Another mnemonic.
Yep, look it up.
Not now.
Cool.
Mark.
Okay, and then in the emergency setting, you do your A to E, okay, pop in a couple of wide bore cannulas, fluid resuscitation, okay, checking their potassium levels, giving them insulin and potassium. And then if their blood glucose levels drop below 15, then you can give them the dextrose. Okay. And follow up with the GP, patient
15.
education.
Isn't 15 quite high?
15, yeah, I would think so. I don't know
for diabetics, so you're right. Yeah. I think they want...
I thought most people want to keep it between 8 to 10.
I think diabetics,
6 to
they don't
10.
want you to go too low because then you risk, too much insulin, like too low blood sugar.
When you do insulin.
When you use insulin, yeah.
What the heck?
Yeah.
Okay.
Cool. Okay, we're done for today.
Thanks, Dan. That was good.
Lovely. Thank you.
for listening.
Okay. Thank you, everyone, for listening. On behalf of myself, Jason, Jamie, and Adian, I hope you enjoyed that and got something from it. Have a good evening or day, afternoon. Bye.
Yeehaw.
Thank you.
Thank you.
Absolute insulin deficiency, bitch.
Thanks for listening, guys. If you liked this episode, feel free to check out the rest of our episodes available on Spotify. Leave us a review and a like. And don't forget to check out all the other resources, including Anki decks of each of the conditions we talk about on the podcast, available on the 1PM Notion website. Thank you.